Yeah, so I think we now have plenty of time for our live Q&A, and I think we can segue into that and have all our panel discussants participate in the discussion. So before we get started, now that we're moving into the live Q&A, I wanted to let you know that we have launched the post-activity survey questions on the polling tab that is next to the live stream feed. And we will review results of the pre and post-activity survey before the end of this session. So on the docket is a discussion of immunotherapy agents and molecular targeted agents in esophagogastric cancer. I think the neoadjuvant or sphincter-sparing treatments of rectal cancer, and now the evolution of next-generation sequencing and how it's going to impact on our practice and trial design. So we also have live questions from the audience. And let's just make sure that everybody has and certainly feel free to pitch in if you have any comments about the questions. So maybe we can start with some of the live questions that were submitted, which I have on my laptop here. Okay, so there's a question about the management of HER2-positive esophagogastric cancer. Maybe Dan, you can field this question. What is the role of maintenance trastuzumab in patient with an ongoing response?
Yeah, that's a great question, and I didn't really focus on that in the talk, but you know, the studies that are being run are usually stopping the platinum-based therapy and then continuing the 5-FU-based component, and then with or without the targeted therapy or placebo in that setting. And so I think there's merit in continuing the trastuzumab with the fluoropyrimidine, and that's what I do routinely in my practice. Similar to colon cancer with Optimox and all of these other strategies, I also build in chemotherapy holidays completely, including from trastuzumab if patients are doing very well, for 6 to 8 weeks at a time, and then reintroduce that at time points, either if they're progressing, et cetera, and only declare the regimen failed if they progress on the therapy.
Yeah, that issue was actually allowed in the original TOGA trial, and it always disappointed me that there was never any follow-up on, did anybody actually do that? Just do trastuzumab alone? Because we really have very limited to no data about the efficacy of trastuzumab alone. Right. We know in breast cancer, we recycle trastuzumab, over and over again into later lines of treatment. But I tend to favor continuing fluorinated pyrimidine with trastuzumab as well as a maintenance. Because we really don't have data, even though the TOGA trial did permit that, they never reported any outcome data for those patients. And certainly, if patients have had a protracted benefit or the rare complete response, sometimes we do consider trastuzumab alone maintenance, but there's really not a lot of data. Maybe
Yeah, I was going to say I don't use trastuzumab alone, just to make that clear too. And it's very similar and akin to like 5-FU and Bev and colon cancer and the Bev alone question. And I don't do that either for the same reasons.
Yeah, maybe we can have our colon cancer colleagues comment on biologic maintenance therapy alone, including Bev combinations, EGFR. Are they viable maintenance strategies on their own?
So I can start and then let I'll correct things, but I'd say absolutely, maintenance biologics with Bev. I think there's, reasonable data suggesting the benefit of that approach. The data on cetuximab is accumulating there. I think that, the U.S. utilization of cetuximab or panitumumab, for that matter, in the first line is growing some. So this is a question that we're still addressing. I'd say in clinical practice, I tend to keep the biologics going in the maintenance setting, and that would probably be by default unless I get knocked off of that with some clinical data in the next year or two.
So biologics alone or biologics plus fluorinated pyrimidine?
With 5-FU, yeah. Thank you, David.
Yeah, I agree. I agree, and that's particularly important with Folfox or Kpox, Bev. We want to avoid the oxaliplatin neurotoxicity. So we try to switch people to a maintenance strategy to lessen that risk.
Yeah, and I think there's always a room for chemotherapy, maybe a little more in colon cancer than esophagogastric, given the aggressivity of the disease. But patients, clearly do benefit from sometimes short chemotherapy holidays as well. So another question for us. I have two computers here, so excuse my turning away from the screen. So this is an interesting question. I think this is going to be addressed in one of the debates this evening. When we have a patient with metastatic esophagogastric cancer that looks like they've achieved a complete response in their metastatic disease, do we do surgery on the primary? So we are going to talk about the treatment of oligometastatic disease, the debates about ablative strategies. My argument with chemotherapy and complete responses is if it ain't broke, don't fix it. It means that patient is benefiting from treatment. What I've seen in practice over several decades is when I stop chemotherapy too quickly, that complete response goes away. Whereas patients that tend to maintain such responses, I usually continue treatment even beyond a year or 2 years or longer. And Dan, any comments?
I totally agree with you. Upper GI cancers, including esophagogastric, when we are fortunate enough to get that nice response in metastatic disease, it doesn't behave like oligometastatic colon cancer. And addressing it in that manner, I think, is not the right thing to do. And then you could say if you super select patients who are now, say, 3 years out and have this, then our discussions at our multidisciplinary tumor boards are, why do anything different? They're doing so well. Now you're going to impose this major surgery when maybe they're on this extreme tail and you don't have to. So I think my position would be exactly the same as yours there.
Yeah, and sometimes, they achieve, if you're really going to document a complete response, you need to do an endoscopy because just because the scan looks better and the PET scan is normal doesn't mean there's cancer there. But this will be a debate topic, so I'm promoting that. Please stay tuned for later in the evening. We're going to have a debate about this issue, about the role. Nobody debates it, I think, oligometastatic colon cancer, but does gastric and esophagus cancer behave the same way? I think that's really.
We have a trial now, the ECOG-ACRIN.
Yeah, we'll talk about
83. Yeah,
we're going to talk about that later tonight. I don't want to digress too much. Okay, and I was hoping to see questions about the ESMO. I think the ESMO presentations are very provocative. We had potentially 4 practice-changing presentations about the use of earlier line immunotherapy. And here's a question. Based on Checkmate 649 results in an enriched population of study, should we consider to use Nivo in PD-L1 negative patients as opposed to the CPS 5%? Maybe Dan, you can address that question.
Yeah, I think that the data are very fresh, and that I think we need to see more information before I really commit to treating those patients that are CPS 0 particularly. The way the data were presented are that they're lumped in with the high levels, and so you see everything there, and the averaged curve actually gets significantly worse compared to the CPS 5 or higher. And so I would like to see those patients individually and see what they're doing. Based on all the prior studies, I would expect very minimal, if any, benefit there. And, it wasn't presented, and even in the forest plot, by the CPS scoring. And so my suspicion is that it won't be as impressive when you do look at it individualized, but I can't say because I haven't seen it. So for now, I would not do that, no.
Yeah, I think that was disappointing about the data presentation because they didn't actually show survival curves of the individual subsets. They kind of pooled it together, and the hazard ratio went down to 0.8 for all comers. And probably if you look at the PD-L1 negative patients, it'll be even less. Although the forest plot did trend. The PD-L1 negatives, there was a trend, but we really have to see what the data show. But certainly the primary endpoint in the CPS 5% or higher was made, and I think that certainly will change practice. And then what about the Asian data where they didn't see a survival benefit, but they did meet the PFS endpoint?
Yeah, that's another one. And just to comment on that previous question that you mentioned, that the PD-L1 trended in the forest plot, but that PD-L1 was by TPS scoring. And so the nuanced differences there are very important, and the CPS scoring has not been shown yet in any fashion. So, and then in terms of the Attraction 4 study, which was an all-Asian study, there the primary endpoint was PFS, which was met of CAPOX or SOX comparison, S1 being their oral fluoropyrimidine, not available to us, and with placebo or Nivo. And it showed a benefit. And the first thing to note is, their PFS medians are higher than ours all across the board, even in their control arm. And then their OS curves, on the other hand, were similar. Both had median overall survivals of 17 months, which is outstanding in from our perspective, and always seen with Asian studies, they tend to do better. So there's a lot of things to discuss. It's a smaller size study than 649. It's placebo controlled, and 649 is not. And there's a lot more crossover to immunotherapy in later lines on the Asian study. About 25% of patients get post first line immunotherapy, whereas it's lower in the 649 study. So there's a lot of differences in makeup, but all Asian versus a global study. And so it's hard to tease out a lot of these things. But overall, and the last part is that they don't do any investigation by CPS or PD-L1 expression at all. That's an all-comer study, and it's not broken down by that. So maybe if you look at the highest level PD-L1, their OS will be better, and we have to see those data.
Yeah, just before we move away from the discussion of immunotherapy plus chemotherapy, I just want to throw out the question from my colorectal colleagues. Given the positive data for first line, pembrolizumab and mismatch repair high colon, is there a role? We haven't seen the survival data yet, and we know that there was a certain degree of sort of early progression on immunotherapy in that colon cancer study. So where do you see the future of chemotherapy plus immunotherapy in mismatch repair deficient colon cancer, or should it be dual targeted immunotherapy?
Yeah, I think, so two good questions there. I think my sense is that there is a little bit of an early progression, as you mentioned.
It's 29%.
Yeah, right. So there is a bit of a crossing of the curves there. And so there's a good rationale for combining with some chemotherapy, perhaps to address that. I think the question is, does that combination actually improve that long-term durable control? Meaning, does it raise the tail of the PFS curve there? And I think we now are at the fortunate position where the bar is much higher, and we're really trying to figure out how many patients can we get into that really long, durable disease control. And so it's a bit of a trade-off between that early progression, but I think PD-1 does have to be part of that first initiation, because what you don't want to do is have a patient start on chemo, not be able to cross over because they decline too rapidly and not get the potential benefit of a PD-1. So I think at the moment, the evidence still favors starting with a PD-1 for that reason, but I'm very optimistic that a chemo combination with PD-1 may ultimately be better.
Yeah. Al, any comments?
You're on mute.
Yeah, Al, can you unmute?
Yeah, I think we really have to figure out these early progressors. And it's why it's recommended now that we follow our patients pretty closely when we introduce immunotherapy for this group. And, it is a significant factor. So I'm hopeful with the body of data that's being collected, we can get some signals. Maybe Scott has some ideas of signals now how to identify those patients.
Yeah, it's still still areas in discussion. I think it is fair to say that, when you look at the degree of immune infiltrates and some of the innate immune engagement, even within the MSI high, there's still some heterogeneity there. So I think there are some low-hanging fruits that can help try to identify those. The question comes up, if we have a fancy biomarker, you're going to be able to get that tested and deployed in a timely manner to help guide patient management, or you better off just starting and keeping a close eye on the patient, as Al mentioned. And I think that's a bar that we need to make sure that we address.
Yeah, and I think we should stress again that mismatch repair immunohistochemistry should be reflex. With all, they get a colon cancer biopsy, whether it's a polyp or a metastatic disease it's got to be the first thing that they do. We shouldn't have to wait to chase our pathologist down because the argument, we don't have the mismatch repair IHC yet, we can't make a decision. That should be established from any biopsy that's done, both in metastatic disease and localized disease. So why don't we shift gears and talk a little bit about rectal cancer. We had the debate about short versus long course radiation. And the question from the audience is there any patient now in 2020 that should get the SOUR approach, or should we now adopt total neoadjuvant treatment based on the recent ASCO data?
I favor total neoadjuvant treatment. I think that one of the things that I tried to point out with Rapido was without full course chemotherapy consistently given in the short course patients, their outcomes were worse by 7%. So to me, I would favor giving this all up front, a la the Oprah trial. If you're going to do long course, and follow the Rapido if you're going to do short course. But I would prefer it up front and putting surgery as the caboose anymore.
Yeah, Dr. Thomas. You have to unmute. You have to unmute.
Hello?
Yeah, we got it.
Okay. Okay, good. I would agree with those comments. I think that total neoadjuvant is really the most appropriate way to move forward. I think a lot of the data that I talked about and that John talked about, and some of the trials ongoing now with NRG using a total neoadjuvant approach, and then actually adding a new chemotherapy agent, a new other sort of immunotherapy is really the way to go, and we see that in NRG and with some of our other trials that are ongoing. So I agree with that statement.
I think one of the things you can look at coming down the line is going to be the results of the Prospect trial. So as I talked about earlier, if I'm looking at a patient who has T2 and 1, T3 and 0, relatively limited volume of disease, but otherwise would meet the criteria that we would want to give neoadjuvant treatment. With the improvements in TME, with the decrease in pelvic failure rates, and also with the recognition that still a significant minority of those patients are going to fail distantly, then what we might end up finding out in a short period of time, although I think we're going to have to do a couple more comparisons after that, is that for those patients with early moderate volume disease, we should go right to chemo. Radiation may not be needed, a short or long course. They can start with chemo, then they can get to resection up front. And I really look for the next phase of this, not just to be the results of Prospect, but should Prospect show us not to be needed, those of us in radiation oncology, for those early moderate cases, are their overall outcomes going to be better because we got to that chemotherapy, that systemic therapy earlier? That's the way I'd look at it right now for where we're going to be in the near future.
So apropos of that, there was a question, how do we overcome the potential bias of the Oprah trial? Because if you start with radiation first, you give more time to achieve a response. So is it really biologically better, or are we just biasing the better response by allowing more time after the radiation?
Well, it's certainly possible. I'd like to know what Tarita thinks, that you have some bias there. But when we're looking at both of them, I think that we have to be looking at the end result of how many patients are getting to resection and comparative outcomes. And if, in fact, and we have other sites, we alluded to some data as analogous in breast cancer where we're going to shorter course. Well, in other areas as well, I think we have to probably combine a few trials to look at whether or not any delay in the systemic treatment will lead to more distant failures, even though when we are delaying it and giving long course up front, we may have better organ preservation. I don't know that that's clear yet, and I don't think Oprah has shown that yet, and certainly not at 2.5-year data.
Yeah, we don't have survival either.
One of the things I think that some of the newer trials are doing is looking at MRI imaging response after a certain phase of therapy. And I think going forward in terms of newer trials, using that between modalities, so from radiation before chemotherapy, potentially evaluating with MRI to really see what the benefit is to try to avoid and understand whether there is a bias, I think might be a way to proceed.
Yeah, so a few questions about DMMR status. So one is, if we have immunohistochemistry, do we really need the genomic testing to confirm? I think my pathologist would say no. Immunohistochemistry is pretty accurate, although the genomic testing might pick up a patient that we missed with immunohistochemistry. So that's one question. And then the other is MSI testing on the primary or the MET.
So I'll take a stab at this first and say, yes, I think the concordance rate is high between the two different tests, the PCR-based test or the MSI, the IHC-based test. I think the MSI collars that are now being incorporated into NGS are another reasonably accurate modality. So what I always advise is that a single test is probably good, but if your clinical suspicion is high, then it's worth looking for an orthogonal test, right? So as a general screen, it's probably okay, but just recognize that there can be some misses there as well. In terms of location, it's fine to test primary or metastatic disease. The concordance rate is high there, so it's not something that we have to worry about clinically.
Al, any comments?
No, I totally agree with Scott. We're selective when we look for MSI versus IHC. A great advantage with IHC, the pathologist can get us the results very quickly, and why it's being integrated now in so many primary path reports.
So, and any difference between somatic versus germline mismatch repair mutations?
So the data has suggested in colorectal, at least, that their outcomes are the same. So it doesn't matter what what mechanism you use to get there. If you get to MSI high, you derive the benefits and the outcomes that come with the PD-1 inhibitor. Likewise, there's been discussions about, does the presence of a concurrent BRAF mutation modulate the impact of MSI? And so the answer there is no, based on the data. There's a little bit of a hint that maybe there's something going on with KRAS, but we just need a little bit more information, larger data sets to really tease that out.
Hazard ratio is 1 for those patients. So, and a biologic question, why does MSI decrease with increasing stage? It's a biology question, I guess.
Yeah, I think it's prognostic. In general, people do very well. Certainly, early stage MSI patients do exceptionally well. And what else is going on in terms of contributing to the risk of developing metastases? Fortunately, it's a very small percentage of patients currently.
So this was appropriate for the issue we raised earlier. So how can we identify those 30% of patients that progress on Pembro up front with MSI high colon cancer? I don't think we can.
We can't yet. I'd agree. Yeah.
Okay. And just a couple of other esophagogastric questions. How often do you get echoes to assess for cardiac toxicity from trastuzumab and gastric cancer? That almost never happens. So.
Yeah, I think it's become like habitual because it was in the studies to do so, and so I do them sort of every 4 months or so. Certainly, if there's new symptoms or any reason to do so, and they were more frequent on studies, obviously. But I can say I think I can count on a few fingers in the last 10 plus years how many times that's been an issue for a patient on trastuzumab therapy for me, quite frankly.
I do them at most every 6 months. I mean, I know the study, it's every 3 months. It's just ridiculous. I mean, yeah. I don't support it. So, yeah. I think we should move to our polling data. We want to review the polling results. So these are pre and post session questions. HER2 is most likely to be overexpressed in gastric adenocarcinomas of which of the following subtype? Diffuse 15%. That's actually the wrong answer. Diffuse gastric cancers tend to be less expressors of HER2. So, Dan, I don't know if we really addressed that during the talk. I don't know. That's a little puzzling. Diffuse gastric cancers, it's like 5%. So it doesn't mean you shouldn't test for it. And intestinal cancers for gastric, it's about 20%. For esophagus, about 30%. So, next question. I don't think I can advance. Oh, here we go. Trastuzumab deruxtecan is the first HER2-directed therapy for previously treated metastatic gastric cancer to improve duration of response, response rate, overall survival, PFS. So, Dan, maybe you can comment, but it looks like there's a little bit of puzzling post-treatment responses here. It's my understanding all of the endpoints were improved with trastuzumab deruxtecan. Maybe you can clarify this.
Yeah, if you had only the choice of one or the other, I'm not sure if that was how the poll was done, but the primary endpoint was a randomized phase 2 study, and it was showing improvement in all of these endpoints. So the answer is yes to all of them. That was a phase 2 study, and something that came up this morning is that this is now approved in Japan, actually, based on that all Asian study. So a lot of questions arise now. Should we be doing it here now in this country? And so I might strike some caution on that one. I mentioned that in my talk, that there are potential side effects and things like that, and moving it into our patients, which there were no Western patients in that study. And in addition, this is third line or higher, and already people are talking about moving it to second line, where we have active therapy with paclitaxel and ramucirumab. I think we have to wait for the phase 2 study that's ongoing in Western countries. That's a single arm, open label, and also a follow-up study that's planned as a randomized phase 3 global study for second line before we start jumping to conclusions. So I'm not aware that it's even been submitted for FDA approval for any indication at this point from just the randomized phase 2 data.
Yeah, and the pneumonitis rate is about 5 to 10%. There weren't any fatalities in the gastric study, but I think there were some grade 5s in the breast cancer studies. So
and colon too.
But it's a promising drug, and but I agree. I think we have to stay tuned. Next slide. Okay, which of the following treatments for metastatic colorectal cancer targets EGFR dependent on testing for RAS mutational status? Okay, this is a little bit of a no-brainer here. Okay, so I think cetuximab is the correct answer. Pembrolizumab, no, that's MSI. Regorafenib doesn't really have a biomarker, and so I think doesn't look like anything changed with the presentations. Except that 10% that think pembrolizumab requires, well, I guess maybe that they're thinking about the Keynote 177 hazard ratio of 1. It wasn't that pembrolizumab was worse than chemotherapy. It just seemed in that subset that it was similar. Comments from Al or Scott?
I think you summarized it well.
Yeah. Nothing to add.
Okay, next. Which of the following agents is targeted for use in patients with metastatic colorectal cancer and NTRK gene fusions? So larotrectinib is one of the correct answers. There are other versions of this drug that are available. So 90% got the correct answer. Nivolumab. I don't think there's really any. Actually, well, yes, right. Don't we see these gene fusions more common in MSI high patients? I don't know if that means that it is predictive of a benefit of the drug. Maybe that's the issue here. So I'm not sure that NTRK gene fusions would direct me to use nivolumab. I mean, any comments on that? I think that's a point that we do see these more commonly in MSI high cancers. Anything that would impact on nivolumab usage?
No, I think it's in the presence of MSI and NTRK fusion. I would agree. Recommend using a PD-1 inhibitor, just given the durability of the results. Although for targeted therapy, larotrectinib has very nice durability of activity alone. So I think just kind of keeping an eye on that spectrum. But it is an interesting consideration if you're not testing gene fusions regularly, and you're part of your first panel that you're doing, and you have an MSI high patient who has progressed on a PD-1 inhibitor. I would say absolutely, that's a group that you should be doing fusion testing on. I think the prevalence there is probably closer to 20%. So I think if you're not a fan of chasing the unicorns initially, like Al mentioned with some of the testing, that's a good time to go looking.
What about the role of IHC? That's been promoted as a screening test also.
Yeah, I think it's reasonable. There's some technical issues there's some thoughts that maybe the IHC performance is not as great in different tumor types. And I don't think we have a huge number in colorectal. I think if I recall the initial posters looking at that kind of showed that it may not have been the best for colorectal. There may be more data that's out there now that I'm not that I haven't seen, but I think it's reasonable if you don't have access to a good fusion panel.
Okay, let's go to the next question. Last one. Okay, then we have time to answer a few more questions. We have got great questions from the audience. Which of the following methodologies here we go. For detecting NTRK fusion cancer provides the most comprehensive genetic profiling, but has a long turnaround time and displays varying sensitivity and specificity. We have FISH. So that went from 22 to 9%. NGS leads the pack. IHC went up to 9%. Any comments, Al or Scott?
Yeah, I'll say that depends on your center. Sometimes our FISH turnaround times just as long as our NGS, but that's more of an aside. So the difficulty with fusions and NGS is that you need to know, and same for FISH, you need to know your partner. So meaning that you need to know, not only what gene your NTRK you're looking for, but what gene is kind of fused to. because most of those, the way they're set up, kind of require the primer cross. There are some tumor or some partner agnostic tests out there that are probably more sensitive, that allow sequencing just on one direction of the strand, so that it doesn't matter what the partner is, it'll pick it up. Or there's RNA sequencing efforts to look to, again, that'll be partner agnostic. So just recognize that most DNA panels right now will do a reasonable job, but they're not the gold standards.
Yeah, I think we're nearly done. I think these last two questions we addressed, for the neoadjuvant approach in rectal cancer, what drives us to do chemoradiation or chemotherapy first? I think we addressed this. A patient really has kind of a symptomatic local tumor, or that we might want to see a response to chemotherapy before adding radiation. I think we addressed that question. And the OPRA data does suggest chemoradiation followed by chemotherapy might be a better strategy for organ preservation, but it's not 100% proven. And then I think, Dan, you addressed this about from the ESMO data, should we make decisions about earlier line use of checkpoint inhibitors based on PD-L1 status? Maybe you can revisit that before we sign off.
The short answer is yes, we should consider PD-L1 status for two reasons. CPS 5 or higher was the primary endpoint, and that's what's clearly positive, which we all anticipate will lead to an approval there. It's the other patients that we don't know, and that I'm not going to be jumping and doing until I see more evidence to suggest that it's going to actually help them to do so.
Okay, great. So we're now going to take a break. During the break, you can visit the virtual exhibit hall and attend the non-CME product theater sponsored by Lilly, which starts at 11:10 a.m. and is titled Planimation, a short film about treatment planning in gastric cancer by Zev Weinberg and Anindu Chatterjee. Please return at 12:10 p.m. We will resume with session 2. I want to thank my panelists, speakers, for a terrific session, great questions from the audience, and validation of the virtual platform. So thanks very much, everyone. We'll regroup at 12:10.